I'm going to speak just a little bit about my own research, where we're going with genetics and screening, because I know that people keep talking about it. I don't want to overstate genetics, and it's not as if everyone here has a genetic disease that they have to worry about. That's the problem when you talk about genetics. Everybody thinks they have something. The reality is what I'm going to talk about is very rare, although once we understand it better, then we're hoping to be able to apply it. It does fit in nicely with what Andrew was talking about, but I'll explain the difference in a few minutes. So we talked about RCAP, which is a new way to remove tumors that we never touched years ago. These are tumors that wrap around the arteries, like Alice showed you. But I don't want to overstate what Alice said, is this is not for everybody. This is an approach that needs to be tested. So we're actually about to test this in 30 consecutive patients. The data that Alice showed is actually pilot data that we did kind of practicing. Patients were prepared to undergo chemotherapy and radiation and then surgery to remove the tumor with their artery, with the understanding that it's not the standard of care. I saw one of them last night, one of the first ones. I think he's about 2 or 3 years out, and I hadn't seen him in ages, and it was terrific to see him. And I don't know if he's cured or not, but certainly he's a bit of a pioneer himself that he actually underwent. And we have a lot of patients who say, you know, I'll die on the table, it doesn't matter. But we can't do that. I mean, that's not how you practice medicine. So we have to have protocols for all of this innovative stuff. And we're about to open a protocol to study this approach in 30 patients. And Nisha and Ian have actually developed this protocol, and it costs $150,000 actually just to run the study. And PCC has been supporting that. I'm going to talk about OPCS and BRCA. And those other trials that you heard about from Malcolm and Nisha reflect, I think, what is the best part about our program is that we have everybody kind of leaning together with the same purpose. So we have surgeons collecting tumors for pathologists and for scientists and medical oncologists looking at translational research. So Nisha's study where we're actually injecting or giving drugs to patients just to pick up hypoxic areas before we operate is something that you can only do in an institution with a lot of good translational science and a lot of patients and a lot of money. So I'm proud to be working there. We've actually been involved with pancreas cancer genetic research since the mid-90s, something we call the OPCS, or the Ontario Pancreas Cancer Study. It's been funded by various government and private agencies, and we beg, borrow, and steal wherever we can get money from to cover the costs of recruiting all the patients in the province with pancreas cancer. Now, we don't get everybody, obviously, but we approach everybody that we know about, even people in remote areas. We hear about them through the cancer registry, the provincial cancer registry, and we send them letters. And it's always amazed me that 30% of patients in the province who don't know us and are not getting cared for us actually agree to cooperate. These are people that generally have a terminal illness, and they still send in their blood and their tumor and their permission to access them. Now, over the past few years, we've really stepped up the recruitment, again, through the help of PCC, because Anna has been approaching every patient in the clinic for about a year, a little bit more than a year, and her approach is very successful. And when you are face-to-face with a patient, if you don't do it this Thursday, we'll get you next Thursday. And you can wait until the following Thursday, and eventually people agree. It's not by coercion, but I think once their thought process is settled with respect to their diagnosis and what's going to happen, they actually are very willing and happy to participate in research. And I'll show you what we're doing with it. So I do have some of these slides that Anna showed yesterday, but I'm not going to show them because I know that Malcolm and Nisha described some of the study. But again, this is homegrown research, which I find very exciting. It's not always industry sponsored. So this is work that Nisha did in her PhD, and there's other work that we're doing in our lab. And we're seeing the fruits of this work being applied immediately. A friend, one of my trainees and friends, and one of our students, George Zagopoulos, is on his way here. He just texted me from Montreal, bringing his student with him, and we're having a meeting in my lab on Monday just to look at some of her work studying chemotherapy in BRCA positive pancreas cancer. Again, a direct translation of what we think is useful, but something that needs to be improved upon. The PET scan study you heard about, xenografting, the downside to all that terrific work that Andrew was talking about that we've been involved with is all of those genomes, or most of those genomes, that you heard about are resected patients. It's a little bit of a dirty secret that we don't talk about too much. But these are the genomes of only 20% of pancreas cancer, because those are the ones that we got the tumors to stick on the machines. We don't have the tumors of the people who didn't have surgery. So the data that Andrew shows and that we talk about all the time is just really a piece of the pie. It's not the pie. So what we're doing now, and Andrew's doing it and others are doing it well, is trying to get hold of tumors from patients who aren't having surgery. So these are volunteers, in a sense, who are having a biopsy of their liver, or sometimes maybe the tumor of the pancreas, and then they're put into mice. We grow them up in mice, and we're going to sequence them. So this is kind of the next generation of the sequencing of the genome that you just heard about. The BRCA work has also generated a lot of international interest, and the way it happened is we treated Libby with cisplatin. There were PARP inhibitors which became popular for treating women with breast and ovarian cancer, and Malcolm tried to get hold of one of the PARP inhibitors, but the company wouldn't give it to him or Libby on a compassionate basis, because they just started, and if something had happened to Libby, it could really damage the development of this drug. So you can see how the company may perceive what would be considered a compassionate use of a drug. Since then, they've been used. The first generation PARP inhibitors weren't that great anyways, and the second generation PARP inhibitors are now being used. And this is actually a study that came out of Memorial Sloan Kettering in New York, and they've asked us to participate because they know that we have an interest. So our next crop of patients with BRCA pancreas cancer are actually going to be getting this new PARP inhibitor, and we're hoping that it will be even better than what we've seen to date. Princess Margaret, like every cancer center, has molecular profiling. IMPACT is a popular acronym in cancer and in every other clinical trials world. Unfortunately, IMPACT stands for so many different things, and Andrew showed an IMPACT in Australia yesterday, and we have an IMPACT here called Integrated Molecular Profiling of Advanced Cancers. So patients who have advanced disease can sometimes have their tumors profiled the way Andrew showed you. And then Alice has talked about surgery. We've maxed out in surgery. I mean, the arterial resection protocol is probably the limit. Someone may say to me in 10 years, that was a dumb comment, but I have a feeling in 10 years it'll still be true. What we're doing now is we're doing better operations, but it's pretty much the same operation. So it's naive for surgeons to think that they're at the top of the heap and the only group that matters, because we're pretty much maxed out in what we can do, and we're doing it safely. We do 120 Whipples a year at the Toronto General, and with very good results. We now have patients leaving the hospital in 6 days, 75% of the time. Alice developed a care path where patients are pretty much on this path, and that allows easier and improved streamlined care to get them out of the hospital quicker. But that's about it. I mean, we're not curing their cancers just by surgery. We need something better. We need better diagnostic tools, like Andrew was talking about, in terms of profiling before surgery. If a patient's not going to be cured with high certainty, they shouldn't have surgery. I mean, that's just common sense, especially if there's risk to the surgery. So if we had a marker that said you're not going to be cured with 99.8% certainty, you probably shouldn't have surgery, or you should have a lot of chemotherapy for 6 months first, or something else. And if if you have a high likelihood of cure, then you probably don't need chemotherapy before or after. So that's this personalized medicine argument that we're all talking about every day of our lives in cancer treatment. So I focused a lot on genetics and a little bit on prevention. You heard a question about prevention, and of course the issue is, why can't we prevent this disease? The science of prevention is not as simple as you think. There's primary prevention, where we actually stop the tumor from growing. That would be diet, if diet works. The secondary prevention would be picking it up early. So colonoscopy, mammography, PSA, these are secondary prevention techniques, or screening techniques. It's called secondary prevention. We don't have a tool for either. We don't have a primary prevention technique. We don't have a secondary prevention technique. The only risk factor that really seems to pan out is smoking. Seems to raise the risk epidemiologically 2 times normal. Doesn't mean that if you smoke, you're going to get pancreas cancer. Doesn't mean that if you don't smoke, you're not going to get pancreas cancer. These are called epidemiologic risk factors. They're not all or none. We have so many patients saying to us, I lived a perfect life. How could I have pancreas cancer at 62? Well, it doesn't work that way. There's just statistics is the problem. Secondary prevention would be a detection method, which I've been interested in. I'll show you a little bit about it, but we don't have one. So everything is still interventional. The interesting aspect of pancreas cancer is that it's the same as other common, what we call epithelial or solid organ tumors. That would be lung, prostate, colon, brain, breast. All the common cancers seem to take about 15 years to grow from whatever that first event was. And if we knew what that first event was, or even a couple years later, we could pick it up and then we could intervene. We could take out the pancreas of somebody who has a millimeter tumor or a 500 micrometer tumor if we knew what it looked like and who they were. And this study from Johns Hopkins, which is called a molecular modeling technique, which is mostly mathematics, looked at the mutations in cancers of patients who actually came in when they were dying. This was a voluntary autopsy program at Hopkins. Quite amazing. People who were dying came to hospital right before they were going to die, like a day or two, and volunteered to die in the hospital so that they could have a rapid autopsy done to have pieces of their tissues removed for molecular work, because a lot of this stuff requires fresh tissue, which you can't get if somebody died at home, maybe 50 miles away or a couple hundred miles away. So that actually was done through a rapid autopsy program. Quite amazing. And this proved what this paper showed, and it's in Nature, which is one of the highest profile biomedical journals, showed that pancreas cancer takes about 15 years to grow. If you add the 11 and 6 and 2, it's actually more than 15 years. So whatever that first yellow cell is, or the purple one, ironically it's purple, then we could, if we knew what we were looking for, maybe we could do something. And I guess that's the easiest way of putting it. And then the next slide Alice stole from me, because this is the same slide. This is actually, this is a marker that pathologists use as a ruler, and this is a millimeter. And this thing here is a cancer. And this is a Whipple that we did about a year ago. And the pathologist opened it up, and it was 1 centimeter. It was one of the smallest ones I've seen. The patient happened to turn yellow. This is the bile duct that's dilated. And it was interesting to me because I had just read that Nature paper. And this tumor is probably 10 years old. And it's only this big. It's as big as your nail, your baby pinky. So that's the problem with this disease. But you imagine, why can't we pick that up when it's 5 years old and it's only 4 or 5 millimeters? The problem is we don't have a method. There are techniques that are underway, and we're involved with a group at Sunnybrook. Just the same way there's medical oncologists who are scientists, and there's surgeons who are scientists, there's also radiologists who are scientists. And the radiologists up at Sunnybrook are actually world leaders in imaging techniques, particularly in MRI. So they're developing what they call a coil, a new technique that squishes your abdomen pretty tight, because the pancreas is way back here. And we're trying to pick up 2 and 3 millimeter tumors. We haven't got there yet. So we did a study a couple of years ago from 2003 to 2009 where we were doing annual MRI using the machines that we have or had at the time. They're being improved all the time. There's a new one being installed now. So they're always being improved. The MRIs in 2013 are much better than they were in 2003, but that's the way it was. And we were doing annual MRI on people who were genetically at higher risk. And I'll talk about them in a minute. And the bottom line, these are the people that we screened. Most of them had either BRCA mutations or a couple others I'm going to talk about. And the majority of the group of 250 just had a strong family history of pancreas cancer, didn't have any known mutations. And we predicted we would find 5 tumors in 5 years based on the mathematics. And we found 3. All 3, unfortunately, 2 of them had surgery. One of them actually had metastatic disease in between 2 MRIs. Quite terrible. And none of the 3 patients actually were cured. So back to the drawing board. We reported this result, and other groups have said the same thing. So with current technology, we don't have a screening test. So we can't screen you. If you're from one of these families or you're a BRCA carrier, we can't screen you outside of a protocol. So we've actually changed our protocol. We're now doing twice yearly MRI, but we've had to reduce the number of subjects in the study. We don't call them patients because they're healthy people, other than carrying some kind of risk. and we're doing it twice yearly. We just changed it, and we reduced it to 50 people from 250 because we're using Ministry of Health slots. Don't tell anybody. And, but there's a lot of doctors that are actually doing inappropriate screening. So if your family doctor is sending you for an ultrasound or someone you know every year or two, it's a false sense of security, and it's not approved, and it may not work. So it's really very important that these protocols are done on an investigational basis. So I've been studying genetics now since I started. I'm all self-taught. I don't have too many fancy degrees, and many times I wish I did, but I've learned a lot of this the hard way and from my students and others. But genetics can be looked at very simply if you want. That's kind of what I do, although it's getting very complicated in the past few years. And the data that Andrew showed and the way that we're looking at genetics is changing so rapidly, it's a bit scary, even for people who have PhDs in genetics from 10 or 15 years ago. And I'll talk to you a little bit about genetics. And this is a simple way of looking at it. If you take pancreas cancer, like any other cancer, most cases don't have a good explanation. So most of our patients, when you ask them in the clinic, is there anybody else in your family with cancer, pancreas cancer, the answer is no. I don't know how I got this. There's nobody else with it. I lived a good life, and we don't have an answer. We're studying that, but we don't have an answer. But what we think is the low-hanging fruit, and it has borne itself out in other diseases, are the people who have really strong family histories. So that's what we've been focusing on, because it's paid off in other cancers like breast cancer, colon cancer, and others. And that's the 10 or 15% of their familial. So if you look at the familial syndromes, there are families like this. This woman had melanoma or a skin cancer at 33, and then had pancreas cancer at 39. And her grandmother had pancreatitis, but it was probably pancreas cancer. It wasn't well documented. And there's other melanomas. So this is actually called a P16 mutation. It's a gene called P16 that causes familial melanoma and familial pancreas cancer. These are rare, but when we see these, we can detect them. Some of these people, her healthy relatives, in particular her mother, who's intriguing because she's what's called an obligate carrier in the genetic world. She has the mutation, but she's now in her 70s and has never had melanoma or pancreas cancer. And we don't understand that. That's something that we need to understand better. And then this is the popular topic that Libby and others have talked about. This is just one example. It's a pedigree, and don't worry about the details, but there's a lot of ovarian and breast cancer. And as Libby told you, she was well attuned to the ovary and breast cancer risk when BRCA was discussed with her by a genetic counselor, but pancreas cancer wasn't appreciated, even though we published a paper in the mid-90s showing the association of pancreas cancer with BRCA mutations, but I guess no one read our paper. But, the Hopkins group did as well, and it's been kind of a bad secret that is now coming out, is that these genes that cause breast cancer and colon cancer, other cancers, they're not nearly as selective as everybody likes to call them. So when you see in the New York Times, breast cancer gene discovered, you have to be very careful how you read these things, because the media sometimes has a spin. Even Libby would admit that. So this is the way we're dissecting the pie now. And this is one term that you need to remember. You don't have to remember, but what Andrew was talking about was called somatic genetics. Those are the abnormalities in the genome in the tumor. And what I study, or what we're studying, is called germline genetics. That's the genome that you were born with, that you got from your mother or your father, mother and your father. So those are different. Obviously, they contribute to each other, and we can learn a lot from each other. In fact, Andrew and I just struck up collaborations just by him coming here, because his area is different than ours, and there are strong overlap, and we can help each other. So this is germline genetics. So this is called familial pancreas cancer, and these are those little pieces I was talking about. So P16 is it's also called FAM. This is that familial melanoma syndrome. BRCA1 and 2, ATM's another one. Hereditary pancreatitis. Lynch syndrome is colon cancer syndrome. So these account for, you can see, about 5%. So people who have these mutations in their germline that they got from their mother or father, or that are in their family, are at higher risk. This is how we study this. The germline genome, very much the same as Andrew studies the tumor genome. I won't go into details. This is just a recent study. This is from my lab meeting yesterday, actually. We're kind of excited about it. We took 300 people in the province of Ontario that we had in our OPCS database, and we actually sequenced about 300 genes. We found that about 26, and these numbers have to be corroborated, or about 10% of that cohort or that group we found mutations in these genes that I just showed you. 9 of them had BRCA mutations, and there's others as well. So whenever we're doing research or clinical work with families with pancreas cancer, we always look at the genes that we know about first before we start investigating and spending thousands of dollars looking for unknown genes. And we find things that we didn't expect. And for me, a lot of this work from a kind of emotional or passionate point of view arose. I've been doing it for 10 years, but this particular family struck me a little harder than most up until that time. It's a brother and a sister were diagnosed within just a few weeks of each other with pancreas cancer, and they're different, which is interesting. This person had a lot of liver metastases, and this person had a really big tumor that was inoperable. So both, unfortunately, incurable situations, and they were siblings out of 6 in a family. And this is their pedigree. And they're down here. And because it all happened at once, from our point of view, it was kind of a research goldmine because we were able to get all the blood samples. And for us in genetics, in germline genetics, blood is gold because the DNA that we get out of blood is so much more valuable than what we can get out of anything else, like a tumor. So we actually have bloods on 3 people or more people in this family. And we've been looking for the gene that caused this family, this syndrome, for 7 years. I haven't found it. And Teresa and Thomas up there are in my lab, and there's a whole bunch of other people that are trying very hard to find this gene because we think that if this family doesn't have a genetic explanation, then what's the explanation? In the past 5 years, this new technology has come around called next generation sequencing, which is what Andrew was talking about. And this is a way to, what we say, interrogate the genome, meaning look at the genome over about a week for a few $1,000s in each case. And that's what we've been doing because we're hoping that as we look at more and more of these families, we'll start seeing patterns. And the group at Hopkins is doing the same thing. And we collaborate with them as well as others, and we're trying to find the gene that caused that family's pancreas cancer. And then I just heard about another one just a day or 2 ago of a young woman that we're operating on Monday who has 2 siblings, also died of pancreas cancer. So they kind of come in batches, and right when you think, you know, you're kind of stale and tired and miserable, not getting anywhere, then something else comes along. So this is what we've been doing, is we've been sequencing these family members, and we look at the variation in their genomes, and we're trying to see patterns. And naturally, we're looking for a needle in the haystack. We're looking for the same variation, the same gene that was in the brother, the sister, and their uncle. If you notice, the uncle also developed pancreas cancer. There were 4, because their mother also had it. So there were 4 cases in that family. We had blood from 3. And this is the amount of variation in your genome. So everybody in this room has about 20,000 regions of their genome that is different from the person beside you, especially if they're not related to you. Now, if they're related to you, then you share parts of your genome. So if you're identical twin, you have almost the same genome as your twin. And you have half the genome of your mother or father, and a quarter of your brother or sister, I think is right. And you can calculate all this from your cousins too. So we're looking in that family, because of the amount of abnormal variation, natural variation, we want to see what was in those 3 people, the 2 children, the brother and the sister, and their uncle. And it all came down to 25 genes in common. So we thought in 2006, fantastic, it's just one of those 25. You can start writing the paper and call Libby up and, you know, call the newspaper. We're ready to go talk about it, but it wasn't any of those 25, or at least the way we looked at it, we're not sure. And we've been looking at this family, among others, now for 7 years, and we have a few others. So it's a painstaking, difficult project. This is just the data from many other families. This is the way it feels half the time, and this is also scares me all the time. Is, you know, I'm trusting Thomas and Teresa to be reading the gels and the computer every day accurately, and what if they make a mistake? What if they're tired? What if I was doing it and I made a mistake? And that was the end of the project forever, and we just walked right through it. So it's exciting work, but it's a bit scary and frustrating too. We do a lot of work with the Pathology Department, and this is just to put it in perspective. This thing is kind of an ugly specimen. It's a piece of a pancreas cancer. This is all called cancer when you talk about it, but under the microscope, only a little bit of it actually is cancer cells, just these areas here. The rest is just scar tissue. So we actually have a technologic problem too, is trying to separate these little nests of cancer cells from the scar tissue when you're doing this intricate DNA or RNA or protein work. And then the last part I want to describe is what's actually been very rewarding for me, and I don't think that if it hadn't been for these sort of new treatment advances, if I'd be continuing to do this, because it's very frustrating, the genetic work, when you don't find anything after years and years of hard work with so many students that have come and gone in the lab, although I still think we're close. But you have to wake up every day thinking that you're close. But then Libby told you her story, and she told it today in a different way than I've ever heard it. So it's always great to hear her story. It was obviously very rewarding. And about a year later, this other patient came in, and this is intriguing for the surgeons in the audience, like Andrew. Alice, I think, knows the case. And Malcolm can pretend that he's a surgeon, or Nisha. And this woman actually had a tumor, pancreas cancer, here in the body, not the head of the pancreas. It's this black thing wrapped around this artery. And she had a liver metastasis. So this is stage 4 cancer. We would never operate on this person by usual criteria. And she told me that she had a BRCA1 mutation, the same way Libby told us that there was a BRCA2 mutation in her family. So we actually treated her the same way with cisplatin, I think. Malcolm can correct me if I'm wrong, and it was amazing what happened. The tumor shrunk from here to this thing here, which was about a quarter of the size, and it pulled itself away from the celiac artery. And we were all excited, and the liver metastasis went away. You see, the problem here is that chemotherapy can't get rid of metastases with any degree of certainty. It could go away for a few months or maybe a year if you're lucky, but it's going to come back. Chemotherapy generally doesn't do that, but our question was, could this chemotherapy in this person be different than the traditional view of chemotherapy? So we waited 6 months, waiting for it to come back, and it didn't come back. So now, what are we going to do? The surgical crowd would say, most surgeons would say, well, you shouldn't operate on people with stage 4 pancreas cancer because they can't be cured. This operation wasn't a Whipple. It's still a big operation, but not as the magnitude of a Whipple. So we actually discussed it at our conference and decided to operate. And we actually removed the primary tumor, and we cut out the area where the metastasis was, and the pathologist actually saw under the microscope the tract or the path of the needle, just to prove that we removed it, and there was no tumor in the specimen. So to us, this was kind of a new way of thinking about surgery. Now, unfortunately, it's not a happy ending. 2 years later, the cancer did come back, and she actually died of the cancer just, I think, a year ago, maybe. So this is really just a new way of thinking. I wouldn't call this, obviously, a great success story, but it's a new way of thinking, and that kind of plays into what Andrew said, is if we knew the genome of this tumor, or in 20 years from now, people will be, I don't know about this room, but talking about this stuff and saying, God, those guys were so stupid. It's so obvious now, because that's the way it goes with progress. I'm hoping they'll be able to tell us how stupid we were. So what we've been doing, someone asked before, is what about this BRCA testing? How do you know who to test? How can you get tested? Who should be tested? Malcolm answered, or someone answered, that you need genetic counseling, which is true. It's very important that genetic counseling is provided to people before they have genetic testing, because it's not just that person who is carrying the mutation, it's their blood relatives. And it could be children or parents or brothers or sisters. But we decided, because of the experience with Libby and that other patient I showed you and a few others, that we should consider offering this to everybody. And we don't know how common it is, so why don't we do both? Why don't we sequence everyone's BRCA1 and 2 gene, and let's also treat them. So it's kind of a double bonus because you learn two things at once. You find out the frequency, no one really knows, and you treat these patients with innovative treatment, and it'll be interesting to see what happens to them. So we were funded internally by the Invest in Research program, which is an internal Princess Margaret competition, for about $100,000 to do genetic testing for the BRCA1 and 2 genes. But you need a rapid turnaround. So we found Stephen Navrod, who does this work for the breast cancer group in the city, and he actually gave us 2-week turnaround time, meaning we would have an answer within 2 weeks, because patients aren't going to wait much more than 2 weeks for an answer. And we started this a year ago, and then we said, how are we going to capture all these cases, and how are we going to talk them into it and figure out some way to do this ethically and deal with all the counseling issues. So we have a genetic counselor, Spring Holter, who works in my group, and then Anna, who's been terrific at recruiting these people. And amidst all those studies I showed you, she's able to talk to them about the BRCA1 and 2 testing. And we actually started a year ago, and we've tested about 200 people and 250 people, and we found some amazing things. First of all, we found 10 cases out of the 250. So you can argue, was that a good use of 100 grand? Some would say yes, some would say no. I think it's pretty good for those 10 people, and we've also learned something. But some of the cases we found were not that striking from a genetic point of view, and this is one of them. Over here, she had breast cancer as well, but she was 74 when she had pancreas cancer. Doesn't really fit the bill. Her uncle had prostate cancer, and her father had prostate, but they're on different sides of the family, and ovary here. So this kind of fits a little bit, but it certainly wouldn't jump out of the screen if you walked into a breast or ovarian cancer clinic. This one's even more amazing. There's nothing in the family history. Just one of his children, one of his 10 or 8 children, had thyroid cancer, but he had thyroid and he had pancreas cancer at 68. So there's something intriguing about him. Here's another one, pancreas at 62. So they weren't actually striking cases. They weren't particularly young. They didn't have strong family history. So it's very important from a clinical point of view. If we hadn't done it, we would have missed half of them. So we found 10 so far, and we've treated a few. And some of the results have been as striking as you've heard. Some have not been, and we need to delve into this further. So we've written a grant to try to study it. So I could talk forever about this because this is what we do day in and day out. You've heard a little bit about surgery, which Alice has talked about. Alice has done some amazing work with CarePath and improving the quality of care. Again, I think we're at the limit. With aggressive surgery. There's the occasional patient that will push the envelope in and see what happens, but as a standard of care, we're doing good surgery, and surgery is not the answer to this disease. We need better drugs, we need better understanding of genetics.
Thank you.
Okay.